I'm Esther, and I'm presenting my research at the College of Public Health this summer on vacancy rates in rural Arizona hospitals. And right now, the working title of my research is Vacancy Rates of Selected Health Professionals in Rural Arizona Hospitals and Their Capacity to Meet Hospital Service Needs. So just a brief recap on the focus of my research. The questions that I'm asking for this are, what are the vacancy rates among selected health professionals in rural hospitals over time? And are there differences in vacancy rates among different sizes of rural hospitals over time? And just a reminder, a vacancy rate is basically when there's an available position for any selected health profession that isn't being filled, so it's vacant. And then the hypotheses to go along with these questions is that there is no difference in vacancy rates among different health professionals in rural hospitals, and that there is also no difference in vacancy rates among the different sizes of rural hospitals. And so the methodology used for this study is I used cost reports from the Arizona Department of Health Services for 2007, 2008, 2009, 2010, and 2011. And basically these reports are every hospital has to put them out. It details all of their revenue, all of their expenses. It has a lot of details on the amount of full-time employees that they have. It has the amount of beds in the hospital. So it basically is a really in-depth overview of every hospital, and it's supposed to be really reliable because the hospitals use these for their Medicare reimbursements, and so this is why we chose to use this data for our study. It's supposed to be really reliable. And so we looked at 27 hospitals in Arizona outside of the Phoenix, Tucson area. And each condition, so I'll talk about that in a minute, but it's basically all the little things that we're looking at in this study, was characterized by the hospital size, and then within that, all of the data was analyzed over a 5-year period. And so the hospital size was determined by the amount of available beds, and basically an available bed is when there's the proper, I guess, staffing and physical availability to support a patient. So the amount of available beds were classified into 4 different groups. We had hospitals that had 1 to 25 available beds. There were hospitals with 26 through 50 available beds, 51 through 99 available beds, and then 100 or more available beds. So that's how we kind of broke it down to get the different sizes of hospitals. And so some of the main conditions that were tested that I'm going to highlight in this presentation were, we looked at the average total staffing vacancy rates, and so that it didn't, for the average total staffing vacancy rates, it wasn't looking at the specific specialists like nurses or therapists. It was basically an overview for everything for that one condition. And then there was the average total full-time employees. There was the average total LPN, nurse assistant, and registered nurse full-time employees. There was average occupational therapist, physical therapist, respiratory therapist, and speech therapist full-time employees, and the average pharmacist, medical record coder, medical record transcriptionist, and radiology technician full-time employees. So to obtain the averages for each condition, which is what I just previously mentioned in the other slide, the hospitals were organized into bed size, and then the condition data for each hospital over the 5 years was studied, and so we were able to get an average amount for each hospital over the 5-year period. And so once we obtained an average amount for the individual hospitals, we were able to get an average amount for each hospital size. And so using that data, we could compare the averages for each hospital size to look for trends for the conditions and to help answer the research questions. And so before I get to the results, there were a lot of methodological limitations to this study. One of them that kind of came across after I started analyzing the data was that there was a lot of apparent data entry errors. Sometimes you would see, for example, it would say like there's two mental health professionals through years 2007 through 2010, and then all of a sudden there's like 200 for 2011. So you could see that there was probably a few extra zeros added and someone just kind of messed up when they were putting in the data. So whenever we saw errors kind of like that, we had to exclude it from the averages. And also, so the main questions for the study was looking at vacancy rates, and unfortunately, all of the vacancy rates for the individual specialists, there was a lot of inconsistencies, and it just seemed like there weren't really reliable reportings. A lot of the times, the hospitals would report a vacancy rate of 0 over the 5-year period for their health professional. But if you looked at the number of full-time employees that they had, the numbers would vary over the years, and so it didn't really make a lot of sense if a vacancy rate is 0 over a 5-year period, but the actual number of employees there is shifting. So because of that, we had to eliminate all of the vacancy rate data for each of the health professionals from the results, just because it seemed really inconsistent. And so because of that, it kind of focused reshifted the research question. Instead of looking at specific vacancy rates for health professionals, it turned into a little bit of a workforce analysis, and so we were able to really get in-depth profiles for each of these communities and hospital sizes. So the data for the total vacancy rate was still pretty reliable, and there weren't really any inconsistencies with those. So for that, I have here, you can see all of the 4 different bed size groups, and then you can see, for example, 1 to 25 beds had 7% vacancy rate, the 26 through 50 beds had 5%, and so on. And so it shows that there are variations between the different sizes, but because there is no increasing trend or decreasing trend over the different hospital sizes, that there really is no difference in vacancy rates among these different group sizes. And so this is the average total full-time employees for each of these hospital sizes. And so as you can see from the data, hospital size does have an impact on the amount of available workforce. So you can see that it increases a lot as the amount of beds available increases. And so this is the average full-time employee for the nurses. And so you can see here that, again, like the full-time employees, for each of the different subgroups of nurses, it increases as the hospital size increases. And then you can also see that registered nurses have the highest amount of numbers compared to all of the other nurses, which is kind of interesting. And then so for all of the different subgroups of therapists, it has that same increasing trend going along with hospital sizes. However, you can see, for example, occupational therapists for bed sizes, or hospital sizes rather, with beds between 26 and 50 beds and 51 through 99 beds, they both have on average 1 occupational therapist for their hospital. So it does increase when we get to 100 or more beds, but it's not as fast or has as harsh of an increase as some of the other professions, but it still has that general upward trend. And then this is for the amount of pharmacists, medical record coders, medical record transcriptionists, and radiology technician full-time employees by size. And again, overall, there's an upward increase in the amount of full-time employees over the increasing bed sizes. However, if you look at the medical record coders, you can see that hospitals with 1 to 25 beds have on average 2 medical record coders per hospital, but if you go back to hospitals that have 26 to 50 beds, which are larger hospitals, they only have on average 1 medical record coder per hospital. So generally, you do see a rise of full-time employees as the hospital size increases, but here's a case where the hospital size increases, but the amount of medical record coder decreases. That's just kind of interesting to note. And so some discussion on this. So like I said earlier, only one of our hypotheses was able to really be tested because there are a lot of limitations to data. And like I said, our hypothesis that there was no difference in vacancy rates among the different sizes of rural hospitals generally correct. Even though there were some slight fluctuations, there was no trend in the data, so we can conclude that right now. And then the data was able to provide different workforce profiles for these hospitals. So one of my other research questions was looking at if these communities can support an influx of insured people under the Affordable Care Act, and seeing if the workforce there is able to support that. However, right now we're not really able to make any definitive conclusions on that just because of the limited data available and the inconsistencies with the vacancy rates. But if we were to go on and do that, we would need to compare the vacancy rates of those health professionals in Arizona with the national averages and kind of see where Arizona falls in that category. But that's for a different time, I guess. And then I'd like to acknowledge Dr. Velez, my mentor, Dr. Howard Ang, the University of Arizona College of Public Health, who I'm doing the research with, and then Donna, Dr. Huerta, and Jose. And then if you have any questions, that's my email. Yeah, no. It seems very comfortable for you, but it also seems like it sort of closes you off a little bit. Okay, thanks. I appreciate that.
I think the graphs are a little difficult to read, so if you can make them a little bigger.
I tried, but yeah.
My only thing is, I think you're right with the discussion. I just think we need a little more punch with the discussion. What does this really teach us? This doesn't make sense as the size gets bigger, the FTE will go up. So I think we just really need that thing to really think this is why this is important.
Okay. Spend as much time going over the graphs, or should I just kind of let the audience look at them and then that's it?
Yeah, I think we do that a little quicker.
Okay.
As you can see, going up, as you can see, this is going up, this is going up.
Okay. Cool. Thanks.